Good afternoon, and thank you everyone for joining us for this session of our CHPRE Summer Policy Series. Today we are talking about public health and lessons learned from COVID-19. I'm delighted to have Michael Fraser, who is the head of the Association for State and Territorial Health Officials, and ASTO is in partnership with the College of Health and Human Services at George Mason. Thank you so much for moderating today. And we have perspectives from local, regional, state, and national. And so I would like to thank you all very much for joining us and turn it over to Dr. Fraser.
Thank you, Dr. Cuellar. We appreciate the opportunity to be part of this event, and I'm really looking forward to sharing some time with our panelists today. Actually, a couple weeks ago, there was a Senate hearing on lessons learned from COVID, and one of the big debates during that hearing was whether or not it was time to do a lessons learned kind of post-mortem. And in fact, there were several who said, no, we're in the middle of a pandemic. And I think, so it's lessons learned from early response to COVID, and hopefully we can then use this as an in-progress review for improvement and opportunity to think about the future, as we're all so concerned about what's happening nationally with continued case counts in new regions and lots going on. So very prescient, and I'm really pleased to be joined by three experts: Elena Marks, JD MPH, who's the president and CEO of the Episcopal Health Foundation, which is a $1.2 billion philanthropy based in Houston. And being a Episcopalian myself, great to see you so active, Elena. Thanks for all your leadership. The foundation works to improve the health and well-being of 11 million people in the Episcopal Diocese of Texas, which includes 57 counties. So it's a big state with a big region there, and it's based out of Houston. We're also joined by Ned Colange, who's MD, MPH, and president of the Colorado Trust, and also an associate professor of family medicine at the Colorado School of Medicine in the University of Colorado, Denver. Ned was formerly the chief medical officer at the Colorado Department of Health and Environment, and I first met him in that role, I believe. And he also chairs the community guide work with CDC now. Both Elena and Ned are on the board of Grant Makers in Health. I'm glad to have you both with us. And we also have Dr. Reuben Verghese. Dr. Verghese, MD, NPH, is the director of the Public Health Division in Arlington County, Virginia, which is where my corporate headquarters are located. And we're anxious to hear from Reuben about how things are going in Northern Virginia and the Northern Virginia region, and also to publicly thank him for his leadership, keeping my staff and our families safe in our region. We really appreciate that. And certainly our Mason family appreciates you, Reuben, and your team, and all the work that's going on in Virginia. Reuben and I met maybe, I don't want to date ourselves, 20-something years ago in response to the anthrax outbreak, which just seems so banal now, but was certainly a public health emergency at the time, obviously, where we responded as both CDC employees. So Reuben is a wonderful asset and has worked in several local health departments in the Commonwealth of Virginia. So we'll get to our panel in a minute, but I thought I'd set a little bit of context as we get started. And I wanted to start with two quotations. And the first is from Governor Mike Leavitt. Governor Leavitt also served as Secretary of Health and Human Services during H1N1 and was the governor of Utah. And he said, everything you say in advance of a pandemic seems alarmist, and everything you have done after it seems inadequate. And so we're in this horrible catch-22 of asking people to change their lives dramatically and being accused of alarmism, and seeing the increased case rates and the lack of response in some places, and it's just so seemingly inadequate. And so I thought that quotation would be a good way to frame our beginnings. And the other quotation I had is, those who can't remember the past are condemned to repeat it. So I thought I'd think about some lessons, and some lessons in public health response that we've learned that might be applicable. The first lesson is, who's in charge? Who's in charge? The second lesson is consistency in surveillance and epidemiology, case definitions, and the need for real-time data reporting. The third lesson is stockpiling and distribution of stuff, how to do that. The fourth lesson is delays in guidance and what is the right and science-based approach to contain a pandemic. The fifth is our public health lab and clinical commercial lab capacity is strained. The sixth is our workforce is not easily deployed to emerging epidemics, especially in governmental public health where everyone's grant funded and program based. And finally, pandemic will impact those who are most vulnerable, those who lack resource, and those who live in communities that are densely populated, predominantly urban. The unfortunate thing about those 6 lessons are they're part of a 2009 report on state response to the H1N1 epidemic. Those are lessons that are applicable today as well. So the good news is I'm not going to have to spend a lot of time writing a lessons learned article on COVID because I can just copy and paste from what happened 10 years ago with H1N1. Those who can't remember the past are condemned to repeat it. With that in mind, there's some incredible opportunities of COVID. And so as we think about lessons learned, really thinking about what can we do in the days ahead and the months ahead and the time ahead as we try to, again, mitigate and contain this pandemic in the United States. I think we need to focus on bouncing forward, not back. How can we use the billions of new dollars in federal funding to states and territories, to local health departments, to tribes and big cities, not to recover, but to imagine a new public health system that actually promotes health and wellness versus just focusing on healthcare. We certainly have learned a lot about politics and public health, and anybody who says, let's get the politics out of public health is naive. But I think in many respects, the notion that we might have policymakers and leaders who don't pay attention to science and actually discredit it was not in our emergency response plans, that our nation's premier public health agency may not be paid attention to or respected in the way that it should be, is concerning to many folks. And I think that really raises this tension between politics and science. And again, back to the bigger question of who's in charge anyway. And finally, I think we've got huge opportunities to really think about equity and systems change moving forward that are, again, not about recreating a system that doesn't work for everybody that we had prior, but in fact might support and sustain new and innovative approaches to health and wellness that really propel our country forward. And to me, that's what's really exciting about COVID in a really unfortunate context. So to get a little bit of perspective from the field, I'm really pleased to introduce our first panelist and turn some time over to Reuben Verghese. Dr. Verghese is, again, the Director of Public Health in Arlington County. Thanks for joining us, Reuben, and the floor is yours.
I titled this Lessons Learned, One Practitioner's Perspective. And so Michael has already stolen my thunder, but that's okay. So,
oh, sorry.
That's okay. So let's see if I can, says I'm a presenter, which I'm hoping means that, actually I may need help to advance the slide because I can't figure out how to do it, but Frank, if you can, let's see. All right, only have one other slide. So this is the slide. It's maybe busy, but I thought that I would put all of my talking points up front. And how can I give any sort of public health presentation without reviewing the basics that we're doing? But it's a one-liner. Staying home is safer, 6 feet with face coverings for under 15 minutes when with others outside of your household, personal hygiene, cleaning and disinfecting, okay? Those are the things that in this area and throughout the nation and the world, people are still talking about, okay? And so that's the message. The problem is, how do you deliver that message in this changing context? And so And we're dealing with one pandemic, and I lived through H1N1, and I was thinking nothing could be worse than H1N1. Nothing could be worse than the 9/11 response. And I will tell you, both of those responses, now looking back, are a piece of cake compared to what we're dealing with now. And I was just thinking about the infectious disease pandemic, but we have a pandemic of at least two things occurring today. We've got the COVID pandemic, and I use Black Lives Matter as a way to say that the pandemic of systemic racism and the pandemic of COVID are revealing the inequities everywhere. And the consequences are happening to the same groups of people. All of society is affected, but some racial and ethnic minority groups are more affected than others. That disproportionality is something that we need to be aware of and remember very strongly. I've had people locally go, well, you need the data before you can make those conclusions. Well, I'm sorry, but we actually did we did something called Destination 2027 in Arlington 2 years before, which was actually creating a health equity plan for the community. And our data showed where we thought we were going to see the problems, that it was racial and ethnic minorities that were disproportionately affected with health, and we knew the geographies. And so even though we didn't have the data when we entered into COVID, it wasn't hard to predict where we were going to see the problem. Some people were annoyed or angry going, well, you can't do things until you have the real data. Well, if you wait, you're going to also affect people's lives. And, well, we guessed right. And what I've had to remind people is I wasn't guessing. I'd like to get to the point where I truly am able to guess or not able to guess, but the fact that I can guess based on a person's appearance, their skin color, is something I want to stop being able to do. And for really honest, if we had our eyes open, we know where the problems occur, and it's one of the things we've got to get better. We've got to start using the terms like white, black, Hispanic. Call out the colors. Let's be color brave, not color blind. And how do we do the response in the areas now and going into the future? Because all of the pandemics we've seen have had this sort of disproportionality. The pandemics of poor health prior to this, we knew about as well. So it's just something that we need to start as healthcare providers always reminding, we know what the data shows. We can continue to collect the data, but that doesn't mean we shouldn't start acting on that data. We have enough data to act. So I'm going to get off my soapbox and move to my next soapbox. So, and I got the novel part definition from a work colleague. Jim Schwartz is our deputy county manager, but he was famously known back in 2001 as the person who was the incident commander here in Arlington when the airplane hit the Pentagon. And so he's had years of experience dealing with these things. And he's the one early on who reminded us that, novel has two meanings in this context. We've been calling it the novel coronavirus. Yes, it's a new virus. And we need to learn a lot about it and learn how it functions. However, novel also means new. Think about the new ways to be and the new ways to respond. So I think this goes to Michael's point earlier. A lot of people, I think, are clinging to the nostalgia of the past, going back to what it was like before. Personally, I don't see that happening for any time soon, and I will actually challenge the presumption, was it really that good to begin with? If we've had this many inequities, you can't change on the margins. You've got to have system change, system transformation to prevent the inequities that we've been seeing. So novel is another thing we have to keep in mind is how do we start looking at the world differently? Which then means it moves to what we need to do right now, adaptive response. Pandemic requires us to somehow be able to respond at a time when we are building the plane as we fly it. I'm phrasing it a little differently. How do we deal with humanity's need for certainty? I will tell you, I love living at the edge normally. I'm tired of living at the edge. There is a limit for everyone, and I think we all know that. This sort of ability to have to always change, people have known that I've always wanted to at least get 3, if not 4 degrees. I've gotten 2 beyond my bachelor's. Now I'm wondering, am I going to go beyond that? Because honestly, I learn enough every single minute in this job during pandemic. And so how do we help people deal with that at this time? And so we often rely on best practice. The problem with that term, as I've been reminded by a seminal article for me that I can share with folks from the Harvard Business Review using the Canavan framework, best practice is by definition past practice, okay? So we've got to remember, that doesn't mean we throw out past practice. It may be useful. Eugene Bardick, the professor at out in Berkeley, has termed the phrase smart practice, which means, is the practice clever enough for the circumstance you have? I would take it one step further, which the Canavan article by Snowden and Boone talk about. There are times when we need novel practice. And although it's comforting to go to best practice, how do we help people start adopting novel practice? So here's a novel practice that most of you never have thought of, and I never thought of in public health. This is my new public health tool. It used to be a stethoscope. It used to be the back of an envelope. I now have a tape measure. People are really bad at 6-foot distances. I've proven all sorts of people wrong when I pull out my tape measure, okay? In some ways, it's going back to the past, but doing things differently. Helping people to do things differently. Going into spaces, I recently was in a courtroom with judges and lawyers, and we were looking at the processes through new eyes. Do you have to do it this way? One judge was like, are you telling me we don't need tables this wide? It's like, well, you tell me, do you need tables this wide? If you do, we can't fit more people in. That's a very simple thing, but we have to break people of their existing ways of looking at things if we're going to have a chance at moving forward and thriving, because the old ways are not going to work if you need 6-foot distances. Another part of this adaptive response, time. We often hear about sprints versus marathons. I don't think we're in a marathon anymore. I would love to hear by the end of this someone telling me, what do we call what we're going through? What goes beyond marathon without putting the word ultra in front of it? But my point is, as an epidemiologist's heart, we often talk of a person, place, and time. How in the world do we deal with something on this scale of this much chaos/complexity? And that goes to some of the next pieces. The mental health for individuals in society used to be a different experience of person, place, and time. Half of my day is helping people start understanding those adaptive responses. How do you help them with a best practice versus smart practice versus novel practice, and just the sheer length of the operation. My staff have been doing this since January. We're working now since March, 7 days a week, and I've got operations like that. There are people going, wait. When we started, they were going, literally, we can do everything in 40 hours. Even when the only way I showed them was after 3 days of showing them 80 hours of work over 7 days, that they started going, you're saying we need to switch our schedule. Once again, do we do things differently? Culture change. I'm sure most everyone on this call has dealt with some degree of culture change on the organizational level. What I've recognized is we are whole cloth asking people to make societal or human culture changes at this point. How do we do that? Especially when we're used to finding best practice. Perhaps we need to do that equity lens to start looking at our world in a novel way. I'm in the home stretch, and I know I'm a little over time. Peter Sandman has a formula about risk, that risk equals hazard plus outrage. My staff still try to adjust to it. Hazard is what we normally think of risk, maybe the scientific view of risk. But flu happens every year and no one worries about it. There's not the outrage. I'm going to be going to a public school session with parents. I have a feeling there's going to be plenty of outrage depending on which position is going to be taken. Is it stay at home? Is it fully coming back? Or for the folks in the middle? I suspect if I've done it right, there will be 3 groups upset with me. But how we help people understand risk and how we do deal with risk in our communities is something that the public and our staff have a really hard time with. So when I'm talking to a group of people from a university especially, how do we help people understand risk when all these other things are changing? And finally, the greatest lesson that I've learned and I need to remember tonight is how do we extend grace? And it is more than my mother's name. We've got to actually be able to be compassionate and extend that grace because we're all in this new world and it's not so easy. The early adopters may see a way out. They may not be right. And so it is okay to have multiple novel practices. But when people want certainty, they're looking for the czar or the dictator. And this is probably the worst time to have only one way. Maybe in the first couple of days it was true, but this is the time for creativity. And how do we do that and extend grace to folks? So I'm going to leave it there.
Thank you, Reuben. That was great. And I think a wonderful lead-in on grace to the Episcopal Health Foundation. So great to have that part of the presentation. So now it's my pleasure to introduce a new colleague just met today, Elena Marks, who we welcome, and again, hails from Houston and is the president and CEO of the Episcopal Health Foundation. Welcome.
Thank you, it is so great to be with public health people because these are my people. We use the hashtag health, not just healthcare, because we are consumed with trying to get people to get their heads around the fact that health outcomes are largely dictated by things that have nothing to do with health care. And so I always appreciate the opportunity to be with people who are about community health and public health. So I'm going to talk a little bit today about what our foundation is doing in response to COVID. And we're just one foundation. Each of us across the country is doing our own thing in our own way, hopefully with some coordination, but we tend to be independent, different organizations. So about us, we're a relatively new organization. We are the product of the sale of a hospital system that was based in Houston, and it was transferred to another organization. The church, the Diocese of Texas, actually owned the hospital, and so it got $1.26 billion in proceeds from the sale, and it put it into a new entity that it named the Episcopal Health Foundation, and that was in 2013, and I got hired to run it and start it up, and I started in January 2014 and have been building and flying at the same time. Our budget for this year is $48 million. We've got 28 staff members, and we are mostly public health and public policy people. We are not medical people. Our approach is really looking at root causes, trying to look upstream, and really trying to blend together through partnerships and service the public and private sectors, and trying to use our resources to leverage. Because we can pay for innovation, we can take risk. That's what philanthropy is really good at doing. We will never be able to replace good public policy. And so we try to use our resources to help the public sector, because we're primarily working with low-income and uninsured populations, help the public sector do a better job at its job by taking the risk and financing innovation. Sometimes it works, sometimes it doesn't work. In terms of what we actually do on a day-to-day basis, we are largely a grant maker. Out of our $48 million, 32 of that will go out the door in grants. We do a lot of capacity building work, some of it through our grant making, but we also offer all sorts of technical assistance, and we will bring in all different kinds of organizations to help organizations that we care about get better at doing what they're doing. We've got a policy research evaluation and data shop, and we do produce some original data. We also aggregate a lot of data from other credible sources and then translate it into user-friendly language so that our congregations and CBOs have access to high-quality data without having to live in a census data set to figure it out. We've got a team of people who do on-the-ground engagement. Not doing organizing directly. We fund a lot of community organizing groups, but doing a lot of training for our congregations and for other organizations and for coalitions about how to actually engage respectfully and successfully in diverse communities. And we also try to use our leadership where we can, which is why I wanted to join the GIH board along with Ned, so that we can contribute to our field. Next slide, please. This is a snapshot of our current 5-year strategic plan. And this is what we were doing the day before COVID became an actual thing. We work under 3 goals. The first one is really our biggest one, and it's where most of our resources are spent. And that is really to change the health system, which includes the health care system, but isn't only the health care system, so that it is accessible, equitable, and that it actually delivers health outcomes and not just more healthcare. We spend a lot of time on resource allocation and trying to pry some of the dollars that continue to get invested in healthcare delivery in a way that would move it more upstream so that it can actually improve health outcomes. So a lot of work around social determinants and a lot of work around payment reform to try to get value-based payments to actually reflect health outcomes as a value as opposed to just the delivery of medical services. Our second goal is about activating communities, and it's parallel to and just as important as our first goal, and that is the theory that if you want a system to be accessible and equitable and responsive to what communities need to be able to articulate what their needs are and to speak truth to power. And so we spend a lot of resources through grants and through TA trying to help build community level leadership. And our third goal sounds like a one-off, but actually if we could fix this one, the other 2 might get fixed on their own. And that is an investment in early childhood brain development. And this is not about child care centers. This is really about the relatively new but 20-year-old research that shows that the active and appropriate engagement between one caring adult, usually the mom doesn't have to be, and a child up through the age of 3 can physiologically change the brain for a lifetime impact of resiliency and better health. And so we do a lot of work with pediatricians, and we do a lot of work with CBOs that are working with families on the ground. And so this is what we were doing before COVID hit. Working hard. We are in the year 3 of this 5-year plan. And next slide, please, because then there was COVID. Thank you. And so when COVID hit, we did really what we did when Hurricane Harvey hit in Houston almost 2 years ago now. First, we were all hair on fire. Oh my God, we have to stop doing everything we're doing. From now on, we are just on COVID, and how do we COVID? And we thought that way for about a week, and then we went back to our plan and said, well, you know what, the goals that we are trying to advance existed long before COVID, are highlighted during COVID, and will continue to exist post-COVID. And so what we said is we are going to come up with a response that aligns with our strategic plan, because if we're right in our plan and we can actually get a health system that's promoting health and is responsive to all communities, then that's a greater good than anything we might do in the short run. Plus, it's really important to me and to my board that we stay in our lane and that we continue down the path that we have selected and try to find work that aligns. And so here's what we did. We are putting out $8 million in grants. The first $2 million went into the Episcopal Diocese, and what they used it for was actually to keep people employed. The diocese and its churches and its various organizations, it has all sorts of organizations, employs about 2,000 people. And one of the best things that you can do in a situation like this is keep people employed so that they can at least take care of themselves. And so the first $2 million went out the door that way. The next thing we did was decide who we were going to work with in COVID. And we went through our grantee list and our other partnership list, and we came up with a list of 94 organizations, most of whom were grantees, but some were other organizations that we work closely with. And we said that we wanted our response to be devoted to those groups where we already had relationships and who were already walking the same pathway we were walking. They were aligned with us in the long-term strategic goals of actually improving community health and not just delivering more health care. And so we decided that our investment should be through and on behalf of and with those organizations. And so in May, we put out $3 million in grants that were all tied to many applications, but having to do with COVID. So we were covering lost revenues. We were covering costs that you might have incurred to switch your business to online, or if you were a clinic, to reconfigure your organization so you could see people safely or invest in more telehealth. We are about to do a second round of grant making, again, to this list of 94. It'll be another $3 million that will go out the door probably in September. We also recognize that a lot of our grantees are small CBOs that just don't have a lot of know-how. They're like a one-person shop who's running a fantastic program or collaborative. And so we committed $500,000 to a whole variety of technical assistance platforms. We have brought in grant writers for them. We have brought in people to teach them how to use and conduct really good interactive meetings on Zoom. We have found a lot of different needs that they have just for capacity building, and so we will hire whoever the appropriate consultant is and turn them loose for these organizations. We also have a $250,000 research project that is going to look at the impact of COVID on Texans. We do health policy surveys in partnership with SSRS a couple of times each year, and so we added another one that is specifically devoted to COVID to look at what the impact has been, and even asking questions like, will you take a vaccine if one becomes available? And we are doing that. Actually, the total budget for that is about $400,000, but we've got contributions from some other foundations that are going to allow us to do an oversample in the largest regions of the state. And then lastly, we will be rolling out on Monday a loan fund that will be available to community-based clinics to, again, address COVID impacts, the changes they need to make, the sustainability they need to have in order to get through COVID. Our thinking being that with grants, you run out of grant money, you've given a grant dollar, it's gone. But with loans, you can recycle the dollars. And so the loan fund is intended to be an emergency loan fund. It's priced really well, no interest in the first year, 1% in the second year, 3% in the third year, and then it balloons. And we will be providing technical assistance to all borrowers so that they are prepared to have an exit strategy when the time comes. And as we have looked at all of this, and I'm thinking back to, Reuben, your comments about the time frame, we have just in the last like 10 days, gotten our heads around the fact that we're not in crisis mode anymore. We're in a new normal. And so we have gone back to our plan. We are doing the same things we were going to do. We're modifying sometimes the timing or the methodology, but we can't wait for this to be over in order to pursue our plans, which are really built around community health and health equity. And that's what we're pushing forward with. The silver lining I see in COVID, which is really hard to see, is the increased emphasis on equity and the terrible inequities that particularly Black populations sustain year in and year out. And whether it's from COVID or the George Floyd effect, seeing the attention to that, I think is going to help us in the long run as we continue to focus on equity and not have to explain to people this is what it means, because people, the general public's getting a pretty good education on this right now. And also, while we're all focused on, do we have enough hospital beds? Do we have enough ventilators? Is there enough PPE? There's an increased understanding and public conversation about the impact of the non-medical factors, the social determinants of health that really are determining who's getting sick and who's dying from this disease. And so for me, the silver lining is that more people over time will be invested in health and not just health care. So this is just one foundation's response, trying to stay in its own lane and looking for opportunities to be of service during this new normal, first crisis, now new normal. So thanks very much, and I'll turn it over back to Michael.
Thank you so much. That was great. I like to think about the next normal. And then the next normal and the next normal becomes a new normal. But Elena, thank you. That's great. And it's great to hear about some of the work you're doing in Houston in response to COVID and sort of an in-progress review as we continue to think forward. And finally, we round out our panel with Dr. Ned Colange, who again is President and CEO of the Colorado Trust, and also has had a really busy week, not because of COVID per se, but because he's on a National Academies panel that's releasing a report on emergency preparedness this afternoon. We're hoping to get a little bit of a preview, Ned, of that as well, and what you all found in your work at the National Academy. So thanks for being with us.
Thanks, Michael. I'll say ahead of time, in the interest of making sure we have time for questions, I'll probably skip over some of these slides. I've given the task of talking about redesigning public health infrastructure, which in some ways less inspiring than the last two speakers. And so I'm just making sure that our expectations are good, because I'm going to talk about redesign, which means I have to talk about what do we have now. And it's an interesting issue. So, Reuben knows this well. He's played at different levels. But our current infrastructure is really very complex. There's national, which used to just be CDC, but now there's the ASPR, or the Office for the Assistant Secretary of Preparedness and Response. So there are actually two national groups that have to partner with one another in order to address things like preparedness and recovery from something like COVID. Then we have state health departments, and the phrase is, if you've seen one state health department, that's what you've seen, because we all vary. They all vary in how they're set up and how they do their work. Then we drop down to local public health agencies. And because of Louisiana, I have to talk about parishes, but there's county parish health departments, multi-county, city-county health departments. There are some places where the state is the only health department and they have local offices. So there's great variation in how we're kind of set up to do our work at the more local level. And then at the top, there are other emergency management agencies that are involved in disasters, such as FEMA and Department of Human Services. And at the state level, there's a whole infrastructure for state emergency management. So let's start at the national level. And I don't know if there's CDC people on, but this is my view of CDC. They really don't have any authority over state and local public health. We are a federation, and there's a lot of state power. So how does CDC achieve its public health goals? Well, they are an authoritative partner. They also provide direct assistance with expert staff. And then finally, they achieve a lot of ends through money, through funding and national programs. And I just named a few: the Prevention and Public Health Fund, which you all probably realize has had a rocky history since the ACA passed, and is once again underfunded, I think, at this point. Then there are Preventive Health and Health Services Block Grant, which address other prevention pieces of public health. There are specific preparedness grants, other program grants, and then kind of unique programs. And I brought up one because I think it's operative in the COVID setting, the Vaccines for Children program. Now, when we think about state public health, recognize that at the state level, most of our funding is still from federal sources, CDC grants and cooperative agreements. And almost all emergency preparedness is from federal sources. There was a really significant influx after the events towards the end of 2001, specifically the October anthrax events, where this idea of investing in public health preparedness became really great. But I will point out that we have this problem. The farther we're out from a crisis, the worse our memories are. So back to Michael's issue. Our memories just aren't that old, and we live in the moment. And funding has seriously decreased farther out from 2001, and really over the last few years has been all but eliminated. There was a small transient bump seen with Ebola, which is another event that makes us interested again in preparedness. In my experience, and I've talked to others, most state health departments receive little state funding. When they do, it's almost always around something specific like HIV, hepatitis C, or other programmatic issues. And recognize, like everywhere else, funding drives our programs, it drives our activities and our staff. So that's how public health infrastructure works. Most states meet local public health objectives by providing either direct expert assistance or by sharing federal and state funds with local public health departments. And again, so much of that programming, that funding comes across programmatically. The other role of state health departments is really to help take the lead in creating state policy. And at the local level, this is the front line. This is where public health actually occurs. That's the local public health department or a local branch. And they are funded usually with federal dollars that's a pass-through, often through the state health department, also through state and then local dollars. But recognize it's good to be a big county, right? And it's hard to be a little county. And so the robustness of the local public health service depends largely on the size of the service area. There are other agencies with which we must collaborate between state agencies and with federal agencies, and I'll just tell you, experientially, it's very highly variable and not always effective. I will also point out, because I'm talking at a university, that there are often good collaborations with academia and schools of public health. We need collaboration in terms of support for preparedness and response. So both through the agencies, but also with healthcare providers and hospitals, public safety agencies that aren't public health, human service and charity organizations such as Elena's and her work, as well as economic and philanthropic organizations. And this collaboration starts to form the fabric of our public health infrastructure for response to issues. I couldn't not talk about the 10 essential services of public health. And it's so interesting to me because COVID presents challenges to all of these and says, yes, we need to be able to do that. Monitoring health status, diagnosing health problems, in educating and empower people, mobilizing partnerships, developing policies and plans for community health efforts. It's interesting that 6 is enforce laws and regulations, and this is where I always point out that public health doesn't have guns or batons or actually much of anything for enforcement other than to say, I'm from public health. So this is a challenge to us in the real world. We need to link people to health services and provide them, make sure there's a competent workforce, and then look at the quality of those services and look for innovations. And this gets right to Reuben's comments about innovation, and I appreciate those. So what has COVID-19 said we really need? So we need evidence-based recommendations for public health response. So the alternative to everything being novel and new and creative is to make sure we're gathering evidence on that so that we can provide guidance to public health practitioners how to best respond. We need strategic planning and message development and communication, especially to marginalized populations. We need testing programs in state labs and private lab partnerships. We've seen this unique need for support for residential institutions, which are hot target areas for outbreaks. We need to do data tracking. Modeling has been very helpful in making decisions. Contact tracing will be important as the epidemic continues to evolve. And then we all hope that we have a population-based immunization strategy to deploy as soon as possible. So when we talk about redesign, I would say, what do we need to redesign? We have the services, we have this loosely linked structure, but we have incredible challenges. And the challenges are around people, enough of us with adequate training. They're around relationships that are mainly relational now, but sometimes structural and might be better if they're structural. We have to work on our communications up and down those relationships. We must consider the context of the scenario, politics, economics, and trust. And driving the whole issue around redesign, or what we need, is access to funding. So what I think we need is a sustained commitment to and funding of public health emergency preparedness and response services and research. And this needs to be independent of how long it's been since the last crisis. We need dedicated funding to support horizontal and vertical relationships and collaboration. And recognize we could do that through policy and administrative structure. We need to have strategies to assure a trained public health workforce, and we really need to start working on restoring belief in science and depoliticizing public health. You've always heard that. So the challenges we face are many. Unfortunately, our economic and social culture is not suited to create and sustain unused capacity, and that is required to ensure a public health preparedness system. That challenge is operative not just in the public venue, but private sectors as well. Public health is primarily seen as a state and local function, even though it has significant federal funding, and there are many competing priorities for state and, I would say, federal tax dollars. And then this phrase, politics and prevention are natural enemies. No one gets elected for something that didn't happen. It's much greater to create outrage and response, like the comment of, anything we did isn't enough. That's how you get elected in politics, and we need to figure out how to make that challenge not be so great. The last thing I'd like to leave you with are just some recommendations. I think the answer to this capacity has to be cross-trained and used to support other public health functions when we're not in crises. I just don't know how to otherwise create this unused capacity that's necessary. We need to restore what were novel funding strategies like Prevention and Public Health Fund, and we really need to add to that preparedness requirements. Think about novel public-private partnerships and funding strategies, because businesses have recognized the economic impact of COVID and the impact of not being able to respond with a robust public health service. Think about Public Health Accreditation Bureau and how that accreditation might be leveraged to help us have an adequate workforce. And finally, could there be a national policy strategy that can support a uniform public health preparedness and response system? And wrapped in all of that is the overlay of equity and inequities, anti-Black racism, and a culture and society that is not holding up the needs and the rights of those most impacted by this current epidemic. So I'll stop there, and I hope I didn't drone on too long.
Not at all. Thank you. That was just great, Ned. And certainly there's some great themes coming out in all three of our presentations from our panelists. Attention to equity, attention to adaptive problems and adaptive leadership versus technical issues and technical leadership.